everyone. Can you hear me? My name is Trang. Today I would like to discuss about the reproducibility of gray matter measure differences in psychiatric disorder. So thousands of studies have tried to map gray matter changes in psychiatric disorder. The common way to do that is comparing gray matter mean between groups of healthy and patients. By doing that, we assume that there's an underlying patterns, and each group will converge to a brain-core phenotype. And then the brain-core phenotype would then inform us the diagnosis or treatment. However, the literature has shown inconsistent findings, some even contradict. For example, one study found that the superior temporal sulcus is thickened in people with autism, whereas another study found that this reason is thinning. So what are the reasons for these inconsistent findings? Firstly, it could be the methodology. Different studies may have different designs, data acquisition, data pre-processing. The second reason could be the sample characteristics. So study may recruit people from different demographics, such as age and sex, or clinical variability, such as illness stage or medications. Another reason could be the problematic diagnostic construct. So it's widely known that DSM diagnosis are umbrella terms that refer to multiple disorders arising from different causes. So it's likely that these diagnostic constructs do not map cleanly onto a consistent neurobiological phenotype. The other reason could be relying on group means. So recent work using normative model suggests that group mean may not represent individuals. But despite all the reasons, if a core brain phenotype exists, it should be replicable. Otherwise, we should reconsider our effort trying to find this phenotype. So here we want to test if we can replicate any phenotypes among different study sites in different psychiatric disorder. To do that, we collect raw structural MRI from 22 data sets. This includes 5 disorders. We have 59 sites, about 5,000 subjects. Each site have a group of healthy and case scanned in the same scanner. We use unified processing pipeline for this data. And we use SBM and VBM to derive the statistical map representing the gray matter difference between healthy and cases. The results are very similar, so here in this talk, I just focus on cortical thickness result deriving from SBM. So we will obtain pairwise correlation between the statistical map for each disorder. The correlation means how consistent the results are in the same disorder. So if there's a phenotype for each disorder, we expect that the correlation will be high. In other words, we can reproduce the phenotype. So the result here shows the pairwise correlations between 10 sites in bipolar disorder. We show the similar maps with the strongest correlations, and also the maps with the lowest correlation. We obtained the results for 5 different psychiatric disorders, including bipolar, schizoaffective, schizophrenia, autism, and depression. We plot the correlations we plot the density of the correlations and compare with the null. So overall, you see that the correlation is very close to 0, with the medium smaller than 0.2. Even though you can see a slightly higher correlation in schizophrenia. So this is striking for us, what's going on here. Although in the literature there's some inconsistency, we didn't expect that the correlation is so low. So we test with Alzheimer, and actually in Alzheimer you can see a high correlations. So this suggests that if there's a phenotype, we can capture it, but the inconsistency in psychiatric disorder may be because of the heterogeneity. So, but we want to test other effects on the consistency. We develop a way to look at the relationship of demographic and clinical characteristics and the correlations. So overall, even you can see some specific effect on sex and number of participants, no compelling effect overall. We also want to test the effect of sample size. To do that, we first remove the side effect via combat. Second, we combine schizophrenia data across all sites. We then divide the sample into 55 pseudo-sites of 20 patients and 20 controls. We obtain the statistical maps for each site and the pairwise correlations between sites. We repeat it 1,000 times, and we plot the distribution of the inter-site correlations. We repeat it 8 times. Each time we subsample with a larger sample size. Note that when we increase the sample size, we generate fewer sites. Oh, sorry. So the finding shows that the correlation increase when the sample size increase. Once the sample size is about 500 per group, we can get a correlation about 0.7. I have to mention that this is the best scenario because we use the same processing pipeline and the same number of subjects per site. And also schizophrenia was the disorder with the highest level of consistency. But still you can see some effect of sample size on the consistency. So in conclusion, we found little evidence of consistent effect in typical studies sample size in psychiatric disorder. The good news is consistent effects may be achieved through recruitment of sample size above 500 patients, at least in schizophrenia. So with that, I thank all the amazing people and the facility that have this project. And also I had to mention that this project uses a lot of open data. So thanks a lot for sharing your data, and thank you for your attention.
Thank you so much, Trang. That was a really interesting talk. Yes, yeah. So if anyone has any questions, please put them on the app and we can... Oh, perfect. We've got one in the audience.
Thank you. It's really hard work. So my question is, since we already see the effect of the version of the pipeline, the variation in your methods, and also the sample size, yeah, we got not consistent results. So what's the next? Are we going to tell the clinicians that, okay, if you want me to tell you what's the difference between PD, no, sorry, it's like schizophrenia and normal control, you need to tell me the version of pipeline you're using. I don't think this is really reasonable for working with clinicians, right? So what, do you have any suggestions or experience how to summarize this inconsistent information? Thank you.
Yeah, I guess in the point of view of a clinician, they want to find a way for diagnosis and for treatment, right? But firstly, we need to find like the biomarker of the disease or the disorder. And if traditionally we just keep comparing the group means, maybe it will not give the consistent result if you just have a small sample size. So if you're really looking for a biomarker, maybe you need to increase the sample size.
Yeah, thank you.
Hi, Trang. Great presentation, thank you. I was wondering, the higher consistency you found for Alzheimer's, can that just be due to the fact that you included larger studies of Alzheimer's, or it could also be the heterogeneity?
Yeah, great question. The threshold we use for X-type, because X-type we have people scan in the same scanner. So usually X-type can only have like at maximum 50 patient or 50 control. So there's not many differences in the size of this size in Alzheimer compared to the others.
Okay, fabulous. We have time for one more question from the app. So someone asks, why is there a need to divide your samples into pseudosites?
Sorry, can you?
Yeah, of course. Why is there a need to divide your samples into pseudosites?
So we want to test the effect of sample size, right? So we collect all the data together to have a bigger pool, and then we divide it into pseudosites to control the size of the site. And also, we also match the age and sex in each site. So try our best to control all other effects.
Perfect. Thank you so much, Trang. Thank you.